And hello, how are you doing? A new month, and I hope you are inching towards your prelims and university exams, and I hope your preparation is good. So today we have the third session of the answer writing series. The first two sessions we saw a good number of essay questions, how to write them, and also we saw a few short notes, right? Hello Arya, good evening. Hello Siddhi, good evening. So today what I'm going to do is I'm going to start with something called keywords because you know that for a fact whenever you have a essay question, long answer question, most of the time, including general pathology as well as systemic pathology, it's going to be a case history, right? So once you understand and identify the right diagnosis, almost everything is sorted. If you make a mistake in going for wrong diagnosis, everything else becomes wrong. Because if they ask the etiopathogenesis, you'll be writing an etiopathogenesis for a very different disease. So what we're going to do is, the first thing, I will also discuss an essay and also have 10 MCQs here. I had shared in the WhatsApp group the FMG exam. It's a very good exam. I'm going to discuss all the MCQs in that exam because each one of them is potential to come in a long answer question as a clinical scenario, right? So first thing, I'm going to talk about something called keywords. How to diagnose using these keywords, right? We'll take random topics. You can give me any system you want. We'll take the keywords there, right? Only for long answer questions, the scenarios, right? So once we identify the keywords, I want you to think in terms of that diagnosis, and it's always easy for us. Once we solve the case history, it's easy to write the etiopathogenesis, it's easy to write the clinical features, it's even easy to write the treatment for that matter, right? Okay, so let's start. So we'll start with hematology, because hematology is favorite and hematology might sometimes sound very difficult for you over the period of time, right? So I'm going to give you a keyword. I want you guys who is online to comment what do you think is the right answer, right? Keyword in sense, it may not be a word, it may be a little bit of history or a, let's say, a patient age, gender, or a very unique microscopic finding. Anything could be a keyword here, right? So the first keyword which I'm going to write here is, it's an adult patient, okay, with a splenomegaly, and the patient presented with a gallbladder calculi. Can anyone tell me what will you think in terms of hematology, right? I'm specifying it also for you, right? Adult splenomegaly gallstones, everyone. Hi, is this means adult splenomegaly gallstones. What do you think of? Just keywords. The goal is simple. You have to arrive to the right diagnosis in the long answer question in order to make the next step in writing the explanation. I'll write few more things. I want to tell what you think is a diagnosis. Right, wrong doesn't matter, but please do comment. Fine. So let's say it's a child who's, this word is very, very important, who has a transfusion dependent anemia. Okay. See, these are very, very, very specific words. If you see this word, the diagnosis should be exactly the same. No takers of first one. Okay, I'll come to the first one again later. Tell me what is the second one. What do you think of? Hemolytic anemia is very broad, right? I want a particular diagnosis. Arya, great. The first one is a very, very, very classical triad of hereditary spherocytosis. An adult presenting with splenomegaly because of the extravascular hemolysis, and it's a very mild anemia. They will present pigmented gallbladder calculi, right? So this is a very, very classical diagnosis of hereditary spherocytosis. Second one is pretty easy. There's only one transfusion dependent anemia which I want you guys to know. What is the transfusion dependent anemia? There's only one transfusion dependent anemia. What do you guys think it is? That I thought is a very easy one. Okay, let's go to the third one. I want you guys to think about the thing and let me know the answer later, right? But please do comment. If it's wrong, it doesn't matter for us. Fine. Let's say a patient had a hematuria, okay, following a history of fever or infection. Again, I'm talking about RBC disorder. So tell me whatever comes to your mind, right? Great, Arya. It's TAL major for the second one, right? A child with transfusion dependent anemia. There is no other anemia which is transfusion dependent apart from thalassemia major. It's not even thalassemia minor. It has to be TAL major only. TAL major is the only transfusion dependent anemia. Transfusion dependence means the kid cannot survive if the kid is not getting a transfusion, right? That's what transfusion dependent anemia means, right? Tell me what's the diagnosis for third one. Fourth, I'm going a little bit away from hematology, but there's a very likely chance this can come in an exam, right? A patient presenting with a history of fever, cold, clammy skin, and the patient has a reduced urine output. What do you think is the diagnosis? Very, very likely chance this can come in an exam as well, right? Because quite a few first paper, one of the commonest history is this. A patient presenting with fever, cold, clammy skin with a reduced urine output. What do you think is this? The previous one, any takers for this? Hematuria after a history of fever and infection. A trigger-based hemolysis is very, very classical for G6PD deficiency. Okay. Like I said, the next one is not hematology related. It's general pathology if you want a clue. History of fever, cold, clammy skin, reduced urine output. What do you think is the right answer? It's a very, very, very common long answer question asked in your university exams. That's a classical history of septic shock. I'll put a disclaimer here and I want you to understand that as well. Septic shock, you must have read this for sure. You will have warm extremities. I'm not denying that. Okay. So generally septic shock will have warm extremities for the reason because it has vasodilatation, right? When it goes to a terminal stage of shock as presenting in this patient, because there's a reduced urine output, which means all the circulation is diverted towards a major organ, right? So septic shock, initial phase, yes, extremities will be warm. I am not denying that. But as and when it progresses, it becomes a real tissue ischemia, the extremities will become cold. So don't go and confuse here saying that it's a hemodynamic shock. Hemodynamic shock or your cardiogenic shock will never have a history of fever or sepsis. Okay, that's very, very important. Every shock will more or less feel the same, but history of fever makes it a septic shock. Fine. Okay, let's go to another one. Let's see if we are able to diagnose this. Okay, it's a 5-year-old child. There is petechiae in the skin. WBC count shows, let's say, 29,000 cubic mm. There's no other information. What do you think is the diagnosis? 5-year-old, petechiae in the skin, WB shows 29,000 blood count. Whatever comes to your mind. Age is a very, very important clue. Petechiae again is not the exact history, but it's a history which might help us a lot. Petechiae will divert you into bleeding problem, but I have a WBC count which is more important. A leukocytosis, microscopy which shows blast. If microscopy has blast, my diagnosis here will be ALL. Child with blast is going to be ALL. ALL, AML can present with any symptom of cytopenias. Could be just fatigue, could be petechiae, could be fever, anything, right? So ALL or AML does not have a very classical clinical history except for few of them, fine? Okay, next, 6. Let's say an elderly 45-year-old person having generalized lymphadenopathy. Okay, and microscopy shows smudge cells. What do you think is the diagnosis? It's a very straightforward thing. 45-year-old, an elderly patient, generalized lymphadenopathy, microscopy showing smudge cells. What's the diagnosis? Smudge cells is almost diagnostic of chronic lymphoid leukemia. That's a very simple thing, right? So these are few keywords. Before going to your exam, if you feel that this can come as a long answer question, please try to learn the keywords. Keywords is which you solve a long answer questions clinical scenario. The same keywords, trust me, will be useful for your NEET PG as well as your INCD preparation. Don't leave it here, right? It's a long-term process. We learn over the period of time, right? Okay, now let's go to our original discussion. So this is a long answer question from hematology. I want you guys to tell me what is the diagnosis. If it's possible, let's tell the diagnosis. Otherwise, as usual, we have a data-based or a clinical scenario-based approach. We'll go with the same, fine? 32-year-old, presenting with fever, easy bruising, bleeding gums, and profound fatigue. Examination shows pallor, petechiae, and a negative EC is also important for me without significant lymphadenopathy. CBC, yes, there is blood count, hemoglobin is reduced, but a very, very contrast and a very important finding, WBC count shows 48,000 per cubic mm. That's very, very high. With circulating blast, platelet is also less, 22,000 only. Thrombocytopenia. Bone marrow shows hypercellularity with numerous blasts. They have mentioned it as myeloblast because there's no chance in giving me extra clue saying there's Auer rods. Auer rods present is myeloblast. And cytogenetics reveals translocation 1517. Can anyone nail the diagnosis? I have highlighted all the keywords here. This is the clinical history. Easy bruising, bleeding gums, WBC count elevated, platelets reduced, bone marrow showing myeloblast with multiple raw rods. And cytogenetics is the most important thing. Translocation 1517. Can anyone tell me what is the right diagnosis? Anyone? It's a very simple, straightforward question. What's the diagnosis? I don't want any random diagnosis. Exact diagnosis is not a difficult one at all, right? Okay. Now, like I said, whenever you are in a long answer question, try to write down the data, whatever is given in the question, so that you will have an option to get the right answer. Very, very simple. You start with this. This is a data point given. 32-year-old person, right? Acute leukemias can happen in any person. There's no age important here. But APL, acute promyelocytic leukemia, is something which is common in the younger and middle-aged adult. Though this is not how I diagnose, but there's an extra information here. Fever is there in this patient, suggests neutropenia. Easy bruising, bleeding gums, petechiae, which means there is thrombocytopenia. This could be your reasoning why 2-mark question. Thrombocytopenia can be due to the bone marrow being replaced by the blast. Or you know that acute promyelocytic leukemia is one disease which can present with disseminated intravascular coagulation. That can also be the reason for the platelet count being reduced, which causes the easy bruisability, right? Fatigue is there, reason 7.5 hemoglobin, again severe anemia. I won't directly call it a bone marrow failure. The bone marrow is being replaced by the blast. Fine, it's replaced by the blast. That's what's happening here. Fine. WBC count of 48,000, definitely leukocytosis. Can anyone give me a name to this? With blasts having myeloid blast having lots and lots and lots of Auer rods. What is that? See, why did you call it ALL? Cannot have Auer rods, right? Can anyone name this? Peripheral smear showing multiple Auer rods. There's a name given to this. Though the answer is there, I will hide it. Peripheral smear showing myeloblast with multiple Auer rods. I have told this specifically in our classes. If you see this combination, multiple Auer rods and an extremely cleaved nuclei, you think of this diagnosis. What is that? We call that faggot cell, right? Bundles of Auer rods, numerous bundles of Auer rods called as faggot cell, and we have the buttock shaped nuclei. These two are very, very, very characteristic finding, right? Extremely cleaved nuclei, a buttock shaped nuclei, and a faggot cell is diagnostic of one condition, which is acute promyelocytic leukemia or APL, right? The question didn't ask about diagnosis alone. The question asked, let's go back to the question. The question asked, how do you represent a patient according to WHO classification? Again, a simple question to you. This I'm sure you should be able to answer. Calling it as an APML or an acute promyelocytic leukemia, is this as per WHO classification or as per FAB classification, the French, American, British? How do you classify APL as WHO or FAB? AML M1, AML M2, AML M3, AML M4, everything are FAB classification, right? In WHO classification, we call this simple. So my diagnosis based on the above finding is an acute myeloid leukemia with a translocation of 1517. That's a recurrent cytogenetic abnormality. It comes under the subcategory of recurrent cytogenetic abnormality. That's very, very characteristic of this condition. Fine. Or you can write APL or APML, acute promyelocytic leukemia, which is as per the FAB classification. But the right answer should be AML, translocation 1517, as per the recurrent cytogenetic abnormality. It comes in the first group of WHO or APML, right? So diagnosis sorted, APML. Can anyone tell me how many of you made the answer right? You might have not commented, but did you think of the answer as APML or at least AML? See, actually I want the diagnosis APML because only APML will have 1517 translocation. Okay, if you made a blunder, didn't call it APML, called AML, I'm very happy because myeloblast is there. There's no way you can write something other than AML, acute myeloid leukemia, or ROTS is there. If you write anything apart from this, definitely the answer is going to be wrong. You will not get any mark because if you miss the diagnosis, rest everything below will be wrong. or in quite a few cases, please use retrospective. The questions will have the answer. PML-RARA, right? The questions might have clue. This is the only AML we use ATRA as a treatment, right? You please do retrospective analysis or use the keywords and come to a diagnosis, right? Now, let's go second thing. Discuss the molecular pathogens of this leukemia, emphasizing on the PML-RARA gene, right? We have read this. We'll read it once again. I'm sure you'll definitely remember that, right? So first, what is PML-RARA? What does it normally do? Then we'll see what will happen in case of translocation, right? PML-RARA fusion is what happens in translocation 15 and 17. Because in 15th chromosome, I have PML. In 17th chromosome, we have RARA, which is retinoic acid receptor alpha, which gets translocated to PML-RARA, right? So this gives me a fusion protein called as PML-RARA fusion protein. That's the most important oncogenic driver, okay? So what does this PML-RARA do? Retinoic acid receptor alpha, right from your first year, even in your school days you must have read, right? Retinoic acid helps in maturation, not vision. Vitamin A helps in maturation. It helps to mature or differentiate the normal retinal cell into rods and cones. That's the purpose of vitamin A. It helps to mature my skin epithelium. That's why you have white dot spots. Squamous problem is there here in the epithelium, right? And whenever in myeloid series, RARA signaling, which is very, very important for normal myeloid thing, fine? Definitely like that, it'll happen soon, okay? It'll happen, it's very, very important for a normal myeloid differentiation, which means from a blast, you can call it a myeloid progenitor, to a mature myeloid cell, which is nothing but your neutrophil. For me to convert it from a blast to a neutrophil, I need this. Normal RARA is very, very critical for differentiation. This is a very important point. Can come in your reasoning Y question as well. Now let's assume I don't have normal RARA. Because of this translocation, now comes our pathogenesis. Okay. Because of the translocation 15-17, the retinoic acid receptor alpha is going to have a reduced function. It's not going to work properly. Retinoic acid receptor alpha is not going to help in differentiation. Because of this, the only word which an examiner will look for in APML is there's something called a maturation arrest. If you write this word, that's more than enough for me, right? Because of this, I'll end up in having a maturation arrest beyond promyelocyte stage. It'll mature from blast to promyelocyte. That won't be a problem. Beyond promyelocyte, it will not mature. So because the bone marrow is not maturing beyond promyelocyte, right? I won't have neutrophils. You're going to tell me one important critical information here. If my RBC is not there in the periphery due to hemolysis, how will my bone marrow respond? Anyone? Hyperplasia or hypoplasia? I don't have enough RBCs because of hemolysis. What will happen to the bone marrow? More or less. Definitely it'll have hyperplasia. Same problem here, right? Because it's not able to mature beyond the promyelocyte state, you'll have very, very, very reduced or nil mature myeloid cells. When you have nil mature myeloid cells, it's simple. This will go and increase the bone marrow division. The only problem here is I will produce more blast. The same thing will happen here again. The blast will be stuck into promyelocyte. So what will happen? Ultimately, which is a cell which becomes more and more and more? It'll end up in these cells. So these cells will become extremely high in number. That is the pathogenesis in APL or acute promyelocytic leukemia. Two important things here. If anyone asks me what is the cell of origin of APML, for every AML, my cell of origin is your myeloid stem cell. It's the blast, right? Here, they originate from promyelocyte. Fine. Second, do they have blast in the circulation? Every leukemia will have blast. Here, I might have blast, but the most important thing for me is the atypical promyelocyte, right? So in microscopy, what I see is more of atypical promyelocyte, and I will not have blast here. Fine. Very, very nest or nil blast. That's one of the reasons. This is one of the exception for diagnosing AML with 20% blast. I don't want 20% blast to diagnose APML. I will see only atypical promyelocytes in my microscopy, right? So this is my pathogenesis. Simple. I know what is normal. Once the normal goes away, I know what's going to happen. The vicious cycle ends up having acute promyelocyte, right? So that was the second question. The question was asking, just explain me the pathogenesis, the molecular pathogenesis, and emphasizing the mechanism of differentiation errors, right? Third question. Describe the peripheral smear and the bone marrow morphology of this leukemia, and also explain the significance of OR rods. Fine. Significance of OR rods. I'm going to ask you guys, what is OR rods? What are OR rods? Anyone? OR rods are nothing but neutrophilic granules, right? They are the same granules of neutrophils which are in the form of a rods. That's all. That's all is OR rod, right? We'll talk about that soon. But what will I see in microscopy? Peripheral smear as well as in your bone marrow. I'm going to see the same guy. We already read in the pathogenesis itself, right? That forms a link. Microscopy, I'm going to have atypical promyelocyte. If you want extra marks, write this. If you want simple, normal, your aiming is to pass, no distinction, no honors. I just want you to write, I'll have 2 important findings, that's enough. If you want a little bit of more extra marks, I want you to write this, fine? Okay, see here, in microscopy, in peripheral smear, what I'll have is, I'll have anemia thrombocytopenia, that is a part and parcel, but that's not the main disease here, right? What I'll have is circulating abnormal promyelocytes, that's what I'll have. And what do abnormal promyelocytes have? 2 findings, 2 important findings here. These 2 are must to write, not for distinction. For pass also this is enough. It is required for me, right? These abnormal promyelocytes will have an extremely bent or a extremely cleaved nuclei, which looked like a buttock for the person who saw. So it's called as a buttock-shaped nuclei. Because you know for a fact, blast is round. How does neutrophils become? They become folded and forms multiple lobes. That's the initial folding which happens here, which looks like a buttock, right? Second is the excessive number of OR rods. I can have the nucleus here. I'll have bundles of OR rods, right? Bundles of OR rods, that's very, very, very important. And this cell is called a faggot cell. You will see this in the microscopy, okay? See, these are both the exact finding what I'm going to see in APL or APML, right? Actually, these both are not seen in the same patient. Imagine if you have such a thick granule, too much of granule, I won't see the nuclear morphology. So this cleaving might not be clear. If you have so much OR rods, cleaving might not be visible for me because it's obscuring them, right? Actually, these both are the right findings. But APL has 2 variants. Write this if you want extra marks, that's all. I do have a variant called an hypergranular variant. That's where I have bundles of OR rods. That's where I have more and more granules, right? Numerous granules and bundles of OR rods. I do have something called a hypogranular variant. That's where you see lots of nuclear morphology is clear. Because the moment the granules becomes less, the nucleus becomes much more clear for me, right? And both these forms can be seen in the same bone marrow, same peripheral smear. I do have 2 variants, hypergranular variant of promyelocytes and hypogranular variant of promyelocytes. In the hypogranular variant, I see the nuclear morphology. Hypergranular, I see OR rods and others, right? Okay, perfect. But these 2 are must. Even if you don't mention hypogranular, that doesn't matter here, fine, right? That's what I'm going to see in peripheral smear. Do I require bone marrow examination for this? Yes, no, maybe. The answer is no. I can diagnose with 100% certainty in peripheral smear, right? Since the question asks the bone marrow examination, like I said, I don't want a bone marrow examination here. You can diagnose the peripheral smear, do a genetic analysis, prove translocation 15-17, go ahead with the treatment. That's all, right? Bone marrow, I told yesterday in the last class, a common finding for every leukemia, hypercellular bone marrow. Every hemolytic anemia, hypercellular bone marrow, right? You'll have hypercellular bone marrow with increase in number of atypical promyelocytes. And this also I told you in the last class, whenever I'm talking about one lineage being very, very high, like here promyelocytes, what will happen to erythroid and megakaryocytes? It will be suppressed. That's simple, write that. Erythroid lineage, that's your RBC lineage, and megakaryocytes, will be suppressed. I must have told a blanket statement in the last class. Trilineage hematopoiesis. Trilineage, right? Erythroid, myeloid, megakaryocytes. If erythroid is more, other two will be suppressed. If myeloid is more, other two will be suppressed, right? That's how it is. Here, myeloid is more. Atypical promyelocytes is almost filling the blast, bone marrow. So other thing automatically becomes narrow, right? Do I need this for diagnosis? I don't need this for diagnosis, but this is how it's going to be, right? So this is a third part, answer for the third part of the question. What I see in the microscopy, peripheral smear, as well as in the bone marrow, right? Now, let's go back to the last one. I wanted to tell the complication, then we'll go on explain that, right? Describe the life-threatening complication which is associated with APML. Someone said just now, there's a very important complication and this is the only leukemia which presents with that complication. What is that complication? We have an important life-threatening complication, that's DIC, disseminated intravascular coagulation. And also they asked here, what's the rationale behind giving ATRA as an arsenic trioxide as a treatment? That's a treatment for APML. Again, that's a very unique treatment here, right? Great, Siddhi. Fine. The complication as well as the treatment here. First, we'll address the complication part. One of the most important life-threatening complication of APML is DIC or disseminated intravascular coagulation. Let's even write why there is a disseminated intravascular coagulation. Very simple. Promyelocytes are the biggest blast, biggest cell in the bone marrow. It's actually bigger than the blast, right? So you'll have lots of granules, lots of Auer rods, lots of them. And let's say I'm going to draw a tiny blood vessel. Diagrammatic representation is always superior to writing a theory. And when these promyelocytes try to enter the blood vessel, especially the tiny blood vessel, there's a chance they might rupture. Because there are not one, right? There are thousands, tens of thousands, fine? Okay? Right? So once it ruptures, what happens? The granules which will be released in the circulation. The moment granules are released in circulation, it will go and damage the endothelium. The granules released causes endothelial damage. The moment endothelium gets damaged, what will happen? Everyone knows that. It will result in clot. A viva question. Which triad does this alter? Endothelial damage producing a clot. Which triad does this alter? That's one of the important viva question. They must have definitely asked you in the first internal. They'll ask you back in the university exam also. We have a virtuous triad, right? Endothelial damage, then hypercoagulability, then turbulence or stasis. Any one of these gets altered, we'll end up in having a pathological thrombus formation. That's a component of virtuous triad, right? So when the granules get ruptured, it happens. And this does not happen in a single vessel. It happens throughout the body because the blast is going to be in the circulation forever, right? So the promyelocytes, right? So when this happens in multiple places, we'll end up in having disseminated intravascular coagulation or DIC. That could be one of the reasons why my platelet count is reduced, because DIC is also called as consumption coagulopathy. That could be the reason why the patient will present with petechial hemorrhages, bleeding gums, and a lot of them, right? This is one of the important complications, right? And what's the rationale behind giving ATRA and arsenic trioxide as a treatment? So treatment for your APL is ATRA, all-trans retinoic acid, and one more is arsenic trioxide. See, arsenic is a heavy metal. It acts like most of the anti-cancer drugs. It goes and kills them, that's all. It's a heavy metal. Heavy metal is toxic to everything. Heavy metal is toxic to APL also. Blood cells, they are toxic. By default, it's going to kill them, right? Arsenic trioxide is action is simple. They go and destroys the atypical promyelocytes. Okay. There are two ways to clear a problem. One, destroy it. The other one, if I can change the root cause. What is the root cause? PML-RARA was blocked, right? Retinoic acid was blocked. The receptor didn't work. There's one simple way to make receptors work or remove the block. Increase the substrate. That's what we did here, right? ATRA acts on the simple principle. Once there's an increase in the substrate for RARA is retinoic acid, vitamin A, that's all. Once I increase the substrate, automatically they'll overcome the block and it'll make RA function. Okay, it will not be like 100% functioning, but definitely it'll start functioning. The moment it starts functioning, what will happen? The maturation arrest will be gone, and this will result in myeloid maturation. The moment myeloid maturation happens, everything might slowly return back to normal, right? This will happen by default. If they ask this, I want you to add one more information. If they ask about ATRA, I need you to know this and I want you to add in the exam as well, right? You'll read this in medicine, but still it's required here. Because of this, let's imagine I have 1 lakh WBCs, 1 lakh atypical promyelocytes. I give a ATRA. All 1 lakh overnight or over a period of couple of days or weeks will become neutrophils. 1 lakh neutrophils. Will my body struggle? They will, right? They'll definitely struggle, right? So this maturation causes something called a maturation syndrome. Nothing should happen fast. It should be slow and it should be very, very, very steady, right? Maturation syndrome presents classically like your ARDS because lots and lots of neutrophils which are activated goes and clogs your capillaries in the lungs and it will mimic ARDS. Okay, it'll be similar to ARDS. Fine, you'll read how to treat that maturation syndrome when you go to medicine, right? So this is the last part answer. One complication and 2 treatment options we know how to treat as well. APL is a very, very, very unique leukemia. Different, very unique translocation, very different pathogenesis, different origin, different microscopy, and different investigation of choice. What's the investigation of choice for almost every leukemia? Flow cytometry. Here, I would prefer genetics. Flow also has exact findings for APL, but genetics is superior because 1517 is much more characteristic, or a real-time PCR, right? Treatment is also different. Complications is also different here, right? And the prognosis. And the prognosis is one of the best prognosis of AMLs. Amongst the AML, all the different types, and very excellent prognosis is APLs, right? If diagnosed before DIC. But the moment DIC comes, we'll end up in having a problem, right? That's about APL, right? How ARDS? See the whenever my body has excess amount of neutrophils, right? Let's say in normal sepsis, can sepsis cause ARDS? It can. The reason is it's causing endothelial damage. Why does sepsis cause endothelial damage? The same struggle. I have only this much of blood vessel, right? 2 or 3 neutrophils can go. Here, all these neutrophils are newly born, very young, very naive. They are easy to activate them, and the body has lakhs of them, right? So capillary is the place where they get activated and they can damage it. One of the biggest organ which density of capillary more is your lung. So all these activated neutrophils, endothelium will be primed, they go and sit there, they degranulate there, damage them, that causes ARDS, right? That's a common complication in almost any condition where I have huge number of neutrophils. One of the outcomes, fine? Okay, done. Let's look at one short note. I'm sure you know the answer for these, all of them. Tumor markers. See, this is a very simple short note. Write about the definition, importance, few examples, and most importantly, this. The uses of tumor markers and also what is the limitation of tumor markers. Can anyone tell me the definition and importance of tumor markers? What's the definition of tumor marker? Anyone? I'm sure you know tumor markers example, right? This part I'm not going at all. Examples, you are like bosses of them. You'll write a lot and lot of them. How do you define a tumor marker? See, you know prostate specific antigen, PSA is a tumor marker, right? You know CEA is a tumor marker. You know alpha fetoprotein is a tumor marker. Someone is asking me to define it. It's very simple. Prostate secretes PSA. So cancer coming from prostate should also be increase in PSA. That's all. You have to convert into a normal sentence. That's it. You know the concept of tumor marker. You should be able to put down in words, right? Substances, proteins or enzymes produced by the tumor cells or host body in response to a malignancy is tumor marker. I can see them in the blood. I can see them in the urine. Sometimes I can see them in tissues as well. Predominantly blood markers are being evaluated. Tissue and urine markers also there. Robbins has a table where urine markers also mentioned, but not routinely used. These are substances produced by the tumor cells or by the host body in response to the malignancy. That's a tumor marker. Fine. And what's a use? Is tumor marker diagnostic? Tumor marker is never diagnostic. Tumor marker is always, this word is important, it's an adjunct to diagnosis. It's never diagnostic. No tumor marker is diagnostic. It will tell me, yes, possible or probable, that's all. It helps in determining the prognosis and it helps in monitoring the response. All these three are very, very important for me. Okay. As three use cases, it will help me to think about the diagnosis. But more important than that is, helps me to determine the prognosis and also assess how the response is. These two are actually the most important thing than diagnosis. Because for diagnosis, we have lots and lots of methods to diagnose cancer. This is not the only method, fine? Okay. So, the use cases, right? Use of tumor marker screening. Not every tumor marker is for screening. I don't go and screen CA125 for every woman. But PSA is a very, very useful tumor marker for screening people around 50, 55-year-old male, right? Not every tumor marker can be used for screening. I cannot use an alpha fetoprotein to go and screen liver cancer for everyone. You cannot do choriocarcinoma and do beta HCG. You can't do that. Selective tumor markers I can use for screening. One of the important thing is prostate specific antigen. Anything more than 4 nanogram, if you can remember this, remember. Otherwise, just remember, higher PSA, the chance of the prostate cancer is a little bit more. Okay, diagnosis. Again, not all. Like written here, calcitonin, right? Calcitonin is diagnostic of medullary carcinoma thyroid. See, because I don't have much other diseases where I have an excess of calcitonin. It's either parafollicular C-cell hyperplasia or medullary carcinoma thyroid. And parafollicular C-cell hyperplasia per se is not a disease, not a known disease, but not PSA. I can use it for diagnosis, but selective cases. Prognosis, very, very, very useful. And treatment monitoring response, very, very, very useful, right? This is a very simple diagram. See, if I have to, why this is important for me is, if I have to write this in a word, I have to spend 4-5 lines. I will not know how to write it. We will have a khichdi of English. Points, underlining will be time consuming. And the examiner also will not be able to read through what you wrote. But it's a very simple one, right? The marker levels with time. If you want to write x-axis, y-axis, right? Otherwise, ignore. At diagnosis, I gave the treatment. Response, it's lowered. Exactly lowered, right? The moment it starts raising instead of the treatment, we call it a relapse. Use tiny flowcharts like this wherever possible. It's a very simple way. Fine. Now, as of now, no classes, Anika. Fine. It's a very, very simple way to explain a treatment monitoring. This can be useful for anything. For example, can anyone tell me what's a treatment for CML? CML treatment is imatinib. Same thing I can do, right? I start imatinib, okay? This is at diagnosis, the imatinib, and here I can write here, instead of the tumor marker, I write BCR levels on real-time PCR. And this is time. You start treatment and you give imatinib. Everything is good, the levels reduce. But suddenly if the levels increase, I will write as relapse. This diagram can go true for almost every tumor marker and almost every therapeutic response you read ever in medicine. A very simple graph and a line diagram, right? Okay, I'll erase this, but that's how you can present in an exam paper, right? So I can use it for screening, diagnosis, very particularly few conditions, prognosis and treatment monitoring. The most important clinical implication is prognosis and treatment monitoring. Diagnosis and screening is not the important one. Prognosis and treatment monitoring is the most important one, and determining the residual disease. Fine. Okay. Now, can anyone tell me what is the limitation of the tumor marker? We know the use case. We saw the definition. Example we'll go to soon. Can anyone tell me any one limitation of a tumor marker? Okay, this is a problem. What do you think is a problem? Any one limitation? One of the biggest limitation of tumor marker is it lacks sensitivity as well as specificity. Okay, that's an important limitation. The limitation is simple. They have low sensitivity and they have low specificity. What does low sensitivity mean? When I have a 2 centimeter tumor versus a 10 centimeter tumor, 10 centimeter tumor will have more tumor markers. 2 centimeter might not have tumor markers. So early diagnosis might be sometimes troublesome. Not for every case, but sometimes troublesome. CA125 might not be there. Might not be significant enough for me to diagnose. Very low specificity. Very, very important. Elevated PSA, as it's written there, is not equal to prostate cancer. Elevated PSA can even be seen after perirectal examination, can be seen after prostatitis, can be seen in BPH. Like that, CA125 can be seen in endometriosis of the ovary. Right? It can be seen in a cystadenoma. It can also be seen in cystadenocarcinoma. AFP will be elevated in hepatitis and also hepatocellular carcinoma, right? So it lacks sensitivity and lacks specificity. That is the only reason I don't use it for diagnosis. It's an urgent to diagnosis, right? Perfect. That was third part of the question, right? Fourth part of the question, examples. 5-6 examples are more than enough. You might memorize the entire table also. Need not prove here. Have to prove a point because it's just a little bit of it, right? Ben Mohan, I'm from Tamil Nadu. Okay. But Kannada gottu. If you can speak in Kannada, I might understand a little bit. Okay. I'll write a few tumor markers and I want you to tell me what are the places where you see them, right? First is prostate-specific antigen, beta HCG. Common tumor markers is being used. Alpha fetoprotein, CEA, and I'm sure no one ever will forget the CAs, CA125, CA19-9, CA15-5, 15-3. Okay. Great. It's me. Oncofetal antigens, hormones, enzymes, and carbohydrate antigens are the broad categories. Few examples should be more than enough for me, right? Prostate-specific antigen seen in elevated in case of prostate cancer, not big deal to remember. It's seen in choriocarcinoma. Okay. And also can be seen in few cases of non-seminomas. Don't write seminomas here, but I will at least want you to write hydatidiform molar pregnancy. Alpha fetoprotein, never forget HCC, and also it's increased in case of non-seminomatous germ cell tumor, especially your yolk sac tumors. CEA, it's simple. CEA is elevated in any cancer which secretes mucin. Colon, pancreas, lung, common ones, right? Any cancer which increases mucin, right? Any mucin secreting adenocarcinoma, you can write anything, whatever comes to your mind. You can write in pancreatic, you can write in colonic, but any mucin secreting adenocarcinoma, CA will be elevated. Fine. Okay, great. CA15-5 uses, it will be elevated in case of breast cancer. Mostly useful to pick up secondaries and relapse of breast cancers. 19-9 for pancreatic cancer. Okay, and 125 for this. Please don't write ovarian cancers or ovarian tumors. That's a wrong statement. It has to be specified epithelial tumors of ovary. It's very, very important. Don't write any ovarian cancer. It will be elevated only in epithelial tumors of ovary. It will not be elevated in dysgerminoma, yolk sac tumor, teratoma. No. Serous adenocarcinoma, mucinous adenocarcinoma, Brenner's, all the endometrioid, all those epithelial tumors of ovary, it will be elevated, right? So do remember them, fine? It's simple. We have a definition, we have a use, we have limitations, and we have few examples. More than enough for a short note. I'm not looking for pages, right? Write stories in pages when you don't know the answer. Write crisp when you know the answer. Most of us think that, no, I'll write 10 pages. The teacher will give me at least 2 marks. We know that. We've been teaching for many years and we've been seeing papers for many years. Whenever the number of pages increases, the psychology is, okay, this guy or girl has written something, story, not the exact to the point diagnosis, fine? Okay. Great. Thank you, Sanika. Complete it. Come back soon. We'll learn more in second year. Fine. So these are 2 questions we want to talk about. One is about the essay and one is a short note. Now we'll go to few MCQs. Like I said I put in your WhatsApp group, this year FMG exam was a very beautiful exam, full of scenario-based questions. I've taken the exact 10 questions from here. I want you to tell the diagnosis if it's possible for you to tell the diagnosis. I'll give you the exact question itself. The image was there. I'm not given the image. Sorry for it. But even without the image, you'll be able to answer the question. What's the answer? A, B, C, D is more comfortable for us, right? Than telling me the answer. Tell me what's the answer. Yes, it's me. Any tumor which can secrete mucin, CA will be elevated, irrespective of what subtype it is. Even in lung, mucin secreting adenocarcinoma of lung is also there. There also it will be elevated. Diagnosis? "32-year-old painless enlargement of right testis." That itself is enough for me. Beta HCG shows normal. Alpha fetoprotein normal, which means not possible. Not possible. Okay. Microscopy actually showed a nesting pattern of tumor cells with a septa with lymphocytes. That was a microscopic image given. So my diagnosis, classical seminoma, right? Image is not there. I ignore the image. Sorry. Had nests of tumor cells with septa in between. That's the image. Okay, algorithmic. Okay, so the answer is seminoma. Yes, algorithmic insider. As I said, I missed the image. Apologies for that. Fine. It's a seminoma. Fine. Perfect. Okay. Might look very big, but a very simple question. What's the answer? First, tell me what's the diagnosis. Then let's go and look at the answer. Here, diagnosis is very important for me. Every information is given for the diagnosis. Tell me what's the diagnosis. "24-year-old, facial puffiness, pedal edema, hypertension, frothy urine. There is photosensitivity in her. Oral ulcers are there. Joint pain is there. Lab shows positive for ANA and double-stranded DNA. And serum complement levels are low, along with proteinuria is there, right? Can I tell the diagnosis will be lupus nephritis? Almost everything related to lupus is there, right from the young age women. That's also a classical history for me. Photosensitivity, oral ulcers, joint pain, all suggesting lupus. Plus, I have problems of kidney. So diagnosis lupus nephritis. Now tell me, what's the mechanism of lupus nephritis? Option A, B, C, or D? We know lupus, right? Why no takers? What's the mechanism of action for lupus nephritis? A, B, C, or D? It is simple. Lupus is classical prototype example for type 3 hypersensitive reaction, right? The immune complex, which is circulating immune complex, will get deposited in multiple capillaries, will injure them, activate them, and that's how they're going to cause capillary damage, be it in the skin, be it in the head, or be it in the kidney. Any case of lupus, my answer would be option B, which is deposition of immune complex with complement activation, right? Perfect. Diagnosis. A very good question. Diagnosis. "62-year-old person, difficulty in climbing stairs, rising up from the chair, has fatigue and falls. Lung shows a CT scan shows a hilar mass, chest imaging. Which of the following types of cancer is most likely to be associated with this condition?" This is one of the classical paraneoplastic syndrome. We have read about Cushing's as a paraneoplastic syndrome, right? Hypercalcemia as a paraneoplastic syndrome, right? We also read about SAADH. There's one more syndrome. Some of you might have heard this for sure. Okay, we have got two options for B, three options for B. Anyone else? Have you heard this? There's a syndrome called as Lambert-Eaton syndrome. It's a very, very classical example for Lambert-Eaton syndrome. Have you heard of them? LEMS or Lambert-Eaton syndrome. Okay, Lambert-Eaton myasthenic syndrome. That's how it is. The primary will be muscle weakness, and a little bit of fatigue and also dryness in the mouth. And it is related to small cell carcinoma of lung, right? A very good question. Generally, we discuss about two things in small cell carcinoma of the lung. In addition to this, we also have Cushing's will be there. They also will have your syndrome of inappropriate area secretion. Plus add one more, it's Lambert-Eaton syndrome. There's a classical history of Lambert-Eaton myasthenic syndrome, proximal muscle weakness with a lung mass. Think of small cell carcinoma, right? You can have a history of Cushing syndrome with a lung mass. I can create multiple scenarios here. I can create electrolyte imbalances, SAADH, right? You'll be able to create multiple clinical scenarios using paraneoplastic syndrome. So please have a look at that, fine? Okay. Hitesh, Lambert-Eaton syndrome is where we have antibodies against the voltage-gated calcium channels in the nerve endings, like someone said, the neuromuscular junctions, right? It's myasthenic syndrome, but not antibodies against acetylcholine receptors, antibodies against the voltage-gated channels, right? So here you'll have antibodies against the voltage-gated calcium channels. If you remember the first year, acetylcholine is released with the help of calcium. That's how it's been released, right? I can block acetylcholine receptors in myasthenia gravis. Here, the voltage-gated calcium channels are blocked, so the effect will be similar to that of an myasthenia gravis, right? That's what is Lambert-Eaton myasthenic syndrome. It's an autoantibody related syndrome, right? It's a paraneoplastic syndrome seen in small cell carcinoma of lung, fine? Okay. Very simple question. Let's see if you can tell the right answer. See, I won't say it is specific for squamous cell carcinoma. It's a finding seen in squamous cell carcinoma, that's all, right? So, but squamous cell carcinoma will have hypercalcemia. I don't have anything such of hypercalcemia there. That's why we're going for this, right? Yes, Malia. What's the answer? Not a difficult one, right? A young person, this is diagnostic of this condition. Weakness of the upper limb, and there is a weak radial pulse. I told you in the class also, it will not be called as a pulseless syndrome. It is a pulse which will be feeble pulse. A pulseless syndrome, compared between arms, one arm is less. That's a classical finding for your Takayasu arthritis or pulseless syndrome, right? Fine. It's option B. That's the right answer. Fine. Great. What's the answer here? "58-year-old presenting with progressive weight loss, altered bowel habits, intermittent passage of blood in the stools for 4 months. Colonoscopy shows an ulcerative mass in the sigmoid colon. Confirms adenocarcinoma." Right? What's the most common gene associated? Right? Among these options, I would prefer KRAS as the better answer. But we read about the adenoma carcinoma sequence, APC beta catenin. If it's there, I would prefer APC beta catenin because that's the starting point. But KRAS is something which is mutated in colonic adenocarcinoma. Yes, BRCA also, but in less incidence compared to KRAS. In an MCQ, it's always choose the best answer, not the correct one, right? Better answer is here for me, KRAS. We go with KRAS here, right? Great. Okay, I don't have an option here, but still, I'm sure that you will be able to tell me the diagnosis and also what's the right answer here. First, let's go to diagnosis, then let's go to the right answer. Yes, Arya. Yes, Himalaya. 14-year-old boy, pain, swelling over leg for 2 months. X-ray shows onion peel or onion skin periosteal reaction. Sagar, why in bone seminoma? I think you're taken from this point alone as seminoma, but I don't think so you'll have bone in seminoma. seminoma in bone, right? PS positive, small round blue cells. What's the diagnosis first? This could very well be a long answer question in your exam. Which one? It's me. Colon cancer. See, since I don't have any more history, just going with KRAS. If there's a history of endometrial cancer or other cancer there, I might think of a Lynch syndrome. What's the diagnosis here? Anyone? Say I'm having a bone lesion in a child, okay, 14-year-old, right, with small round blue cells. We read patterns of neoplasia, right? You should never forget the patterns of neoplasia. Any tumor ending with blastomas, any tumor which is embryonal, and Ewing sarcoma can have small round blue cell. It's a classical diagnosis of Ewing sarcoma. Now, can anyone answer this question? What's a translocation seen in case of Ewing sarcoma? What's a translocation seen in case of Ewing sarcoma? Great Sangha Kalyani. It is translocation 1122. There are two translocations just there, 1122, 2122, anything. Sorry, it won't be BRCA. Okay? Misread as BRAF. My mistake. Fine. It's translocation 1122 or 2122. Both are seen in Ewings. 1122 is much more common. So choose 1122. Fine. Okay. Let's see if we can pick this up. "12-year-old boy brought to the outpatient department with recurrent episodes of mild discoloration of yellowish discoloration of eyes." So I'll write the first information given to me here. Jaundice or icterus. Fine. Physical examination unremarkable, mild scleral icterus. And second information, the patient has unconjugated hyperbilirubinemia. What's the most likely diagnosis? Luckily, all four options are syndromes of jaundice. If you remember syndromes of jaundice, we divided them into two groups. One had a conjugation defect. I must have told you as conjugation gone. That was a mnemonic for us, right? Which is Krigler-Najjar, and the other G was Gilbert. The other two are excretion defects, right? Excretion defects we had Dubin-Johnson and we had Rotar. When conjugation is defective, I'll have unconjugated hyperbilirubinemia. There's no conjugation, right? So obviously every bilirubin is going to be unconjugated, right? When excretion is defective, conjugation has happened, so I'll have increase in conjugated bilirubinemia. So now it's very easy for me, I can ignore this, right? Because the question says unconjugated hyperbilirubinemia, almost everything is there, right? Okay, perfect. And hemoglobin is normal. That means not even hemolytic anemia, right? So now I have to choose between these two. Now I made your life easier. Tell me whether it's Krigler-Najjar or Gilbert. Okay, Sumali has gone for Krigler-Najjar. Others, I want to take an answer. Guess. Let's see then whether it's right or not. There's nothing here that you are going to win or you're going to lose. Make a mistake here so that you don't make an exam. Okay, it's me is gone. Is this me is gone to Gilbert's? Fine. I'm mispronouncing a name. Sorry for it. Krigler-Najjar or Gilbert? The answer is simple. Answer is Gilbert syndrome. Why? Krigler-Najjar presents during infancy. Very early in life. Right? And they're not unremarkable most of the time. Right? Gilbert is mostly asymptomatic. Sometimes mild things might change, right? So the answer is Gilbert based on the age of presentation and based on the way the icterus is manifested. Krigler-Najjar, most of the cases of Krigler-Najjar will present during infancy. They don't present at childhood or adult, right? So age is a clue that will help me to nail the right diagnosis. I would need some more tests to confirm it's Gilbert, but with the given information, answer would be predominantly Gilbert syndrome. Fine. Okay. Very simple one. This had a mistake in the question. I have given the same question what came in the exam. Ignore that mistake and tell me the right answer. Yes. 45-year-old presenting with progressive fatigue, numbness, tingling foot, walking difficulty for the past 6 months. Lab diagnosis revealed anemia. Which of the following is the most likely diagnosis? Not a difficult one. That is megaloblastic anemia, right? All these are features of your subacute combined degeneration of spinal cord due to the myelin defect, what we did in the last time, right? We'll have subacute combined degeneration. Neurological symptoms will be a part and parcel of megaloblastic anemia, B12 deficiency. The problem is vegetarianism is not a history. Vegan could be the right one. Vegetarians don't have B12 deficiency. Vegan people will definitely end up in having B12 deficiency, and B12 deficiency megaloblastic anemia will be the most appropriate answer here. Fine. Okay. Simple one. Some questions are really easy. Something will definitely test your time. It's a simple one. 8-year rapidly enlarging jaw. I don't think you'll forget this. Classical jaw lesion, young African child. Only one thing, it's Burke 8. And I told you to not write as Burkitt, it's Burkitt lymphoma, so that you'll automatically remember the translocation 814. Right? Right? Classical finding. And if translocation is not there, if the gene there, c-MYC is a gene, proton cogene, which is muted in case of Burkitt's lymphoma. Fine. Okay. Again, a simple one. What's your answer? Well, simple one, right? Hematuria, transitional carcinoma, it could be benzidine, aniline dyes, or your related to your painting. Again, it should be the same answer, right? Benzidine or aniline dyes could be then the option. That will be the right answer. A question from chemical carcinogenesis. Fine. Okay, the last one. Everyone online do answer. The last one, at least you should do justice for the question. Very simple question, not difficult at all. Tell me what's the answer. I'll ask one leading question or two leading questions to this. 60-year-old working in a shipyard, shipwrecking industry for 30 years, presents with routine health examination. This occupation puts at him for a particular lung disease. Exposure to which of these conditions, these four things are there in this patient? Is it asbestos? Is it silica? Is it cotton? Or is it coal? Shipyard, shipwreck industry, it is going to be asbestos fiber, right? They are going to get more exposed to asbestos fiber. Asbestosis is the right answer, right? Two leading questions. What do you see in the microscopy of this particular condition? And what's the, we do know there's an increased risk of cancer with asbestosis. A very common Viva question. What's the most common cancer? And what's the most specific cancer in case of an asbestosis? The most common cancer is undoubtedly lung adenocarcinoma. The most specific cancer is undoubtedly mesothelioma. And your microscopic finding, you'll have the ferruginous bodies or asbestos bodies, which will have your hemosiderin coating the fiber, which can be Pearl's positive as well, right? Perfect. Great. Okay. Okay, so we had 3 classes on essay writing and answer paper writing. The primary agenda is all these, right? Almost all 3 classes of mine might have had images like this. All these are made using AI. if I was a student at this point of time, I'd have definitely loved to use Gemini or any other AI which is available for you, because Gemini I'm specifying because they have multiple free options. That's all, right? To know how to present, because I was a person who can conceptualize few things, but presenting is not my cup of tea. If someone has told me, okay, this is how easily you can present, I'd have taken it, maybe would have scored a little bit extra marks, right? Because there are good set of people who are not good in writing a paper, but they know stuff. And if you're stuck there, use your time judiciously, give it a prompt saying that write an answer paper, A4 sheet, properly spaced, handwritten, and easy flowcharts. Put any question there, it will give you an image. Try to use them judiciously. Use AI very, very judiciously, because it will help your life and make your life much easier, right? So that's all I take from here. We had 3 sessions on answer writing. We'll try to have start a array series hopefully by the mid or little bit after 15th of July, and we'll try to cover few more questions, and hopefully you all will do your exams very, very well. Fine. That's a good thing about medicine, right, Siddhi? It has to get confusing. If it's not confusing, it's so easy, everyone will ace the exam, right? See, keep it very simple. Whenever you see any patient, any disease, do not put into your mind that I have to look at the microscopy first. No. I have to look at the radiology first. No. First is always history. Rule out. If you have the age, if you have the history, if you're able to segregate in your mind, okay, this is gastrointestinal system. Okay, this is hematology. It narrows down the differential diagnosis. Have filters, right? So let's take the same question. We'll take the same question and have filter. Easy bruisability, bleeding gums, and profound fatigue. That's a history. So it has to be either RBC, WBC, or platelets. That's all. Nothing beyond that, right? Then went to it. No lymphadenopathy. WBC count is 48,000. Remove RBC and platelets. I have a WBC problem. And I have so much high WBC count. So has to be a malignant WBC problem. I narrow down further. Then I have myeloblast. My answer is sorted. Okay. Try to narrow it down. As much narrow it's down you can possible. It's easy to come to a diagnosis. You have a history of hematuria. Could be RBC, right? Intravascular hemolysis. Could be kidney related problem. If the next question says, next line says, I also have hypertension and proteinuria, I will remove RBC. It's a renal problem. I have hypertension, I have proteinuria, I have hematuria. I have come to nephritic syndrome. I have eliminated nephrotic, I have eliminated other things in renal, right? Then I'll work with 4 or 5 diagnoses, that's all. So once you start to narrow down and start to know how to eliminate things, it's very, very easy to come to diagnosis. Fine. Try doing this, Siddhi. Solve more and more papers. You have all the old paper recalls with your seniors, they'll give you. Solve more papers. Long answer is the easiest one to solve. After that, if you're getting confused in the below part, short answers or these things, be strong in general pathology. If you're strong in general pathology, rest everything will automatically find its way. Okay? All the way, Siddhi. You've been a good student. You've attended regularly. You've studied sincerely. You'll score very well. Don't worry about it. All the best. Thank you, guys. See you in Faray soon. Bye-bye.